I'm Liz Seegert. I'm AHCJ's Health Beat Leader on Aging. This webcast is one in a series of topic-specific training opportunities to brief health journalists on the latest information in a particular health area and to give them story ideas or resources that they can use in their work. Today's topic is how the 2026 budget bill will impact older adults. That's because massive cuts to Medicaid and other safety net programs can have a devastating effect on older people, both the over 65 population and the people who take care of them. It will also affect how some seniors pay for their Medicare premiums. And as a reminder, Medicare open enrollment begins next week, so that's a really important thing to bear in mind. Journalists can help seniors who rely on these programs by knowing the facts and setting the record straight. Joining us today are Dr. Rachel Werner, Executive Director of the Leonard David Institute of Health Economics and Professor of Medicine, University of Pennsylvania Perelman School of Medicine, and Amber Christ, Managing Director of Health Advocacy for Justice in Aging. Our guests will present and then answer your questions. You can ask questions at any time by typing them into the Q&A space. We'll be able to see them and I'll direct them to the presenters. Remember to please use the Q&A box and not the chat. So let's go ahead and get started with Dr. Werner.
Great, thank you, Liz. Thanks for having us here today to do this. I'm just going to go ahead and share my slides. So I want to give just a brief overview of a couple of the effects of HR 1, or the One Big Beautiful Bill Act, before I turn it over to Amber, who will fill in all the details that I forget. So as you all know, HR 1 was the budget reconciliation bill that was discussed and passed in the spring and in July of 2025. And in terms of healthcare impacts, it includes major cuts to federal Medicaid spending. And so the CBO, in their most recent estimates, estimate that it will reduce federal Medicaid spending by about $911 billion. And it will also increase the number of people who lack insurance by about 10 million people. So I'm just going to get a little bit into what those numbers mean and some of the populations that are most affected by this. We talk a lot about the Medicaid cuts in HR 1, and I want to just be clear that what the provisions are that are leading to these Medicaid cuts, because it turns out that many of them are not actual cuts in the direct cuts in the spending on Medicaid, but are provisions that are going to just reduce the number of people who are on Medicaid. So the major provisions are work and reporting requirements for people who are enrolled in Medicaid through the ACA expansion. That's going to reduce Medicaid spending by about 40%. There are also included in the bill a number of provisions that will increase eligibility redeterminations for individuals enrolled in Medicaid, which increase administrative burden for people on Medicaid and reduce the number of people enrolled in Medicaid. And then other provisions that also increase administrative barriers to coverage. There are a couple of ways in which Medicaid spending is going to be directly reduced as well at a federal level. And I've highlighted those in blue here, which are limits to state-directed payments. So the amount that state agencies are paying hospitals and nursing homes will be reduced. And there's also going to be a moratorium on new or increased provider taxes. And so I'm not going to get into the details of those today, but I pointed out to say that those two provisions, which are direct reductions in the spending on Medicaid, actually make up less than half of the reduction in Medicaid spending. And the majority of it comes from provisions that are, in my view, established to reduce the number of people who are on Medicaid. So I want to just move now into some of the special populations that are particularly going to be affected by this bill, focusing on older adults. And one of those populations is those that are dually enrolled in Medicare and Medicaid. And so just as a little bit of background, 12.5 million people are currently jointly enrolled in both Medicare and the Medicaid programs. It accounts for just under 1/5 of all Medicare enrollees. And so these beneficiaries use their Medicare benefit to cover their medical care, so doctors' visit, hospitalizations, post-acute care. But then they also receive assistance from Medicaid for a number of different services, and those include help with the premiums for Medicare, cost sharing from Medicare, and long-term care or long-term services and supports. This is a group of beneficiaries who I would describe as being particularly sick and vulnerable. They tend to be low income, so 87% of them have incomes of less than $20,000. Approximately half are people of color, and they're in poor health. 44% report their health as being in fair or poor health, and 48% have a limitation in their activity of daily living. And so while it's only 17% of Medicare beneficiaries who are dually enrolled, they account for a third of all Medicare spending. The HR 1 has some specific provisions that are going to impact this group specifically, and it's primarily through a program called the Medicare Savings Program, often referred to as the MSP. So the Medicare Savings Program provides Medicaid assistance to Medicare beneficiaries to provide help with covering Medicare premiums and cost sharing. And also an important part of that is paying for prescription drugs through what's called the Part D low-income subsidy. Currently, almost all duals or people who are dually eligible are also eligible for the MSP program. But historically, it's the application process for enrollment in the MSP has been quite complicated. And it's in part due to the fact that eligibility is not only determined based on income, but also based on assets. And the application process to document assets is quite complicated. This results in lower enrollment and lower maintenance of coverage. So during the redetermination process, more people disenroll. During the Biden administration, there were two rules that were put in place that were meant to reduce barriers to enrolling in the MSP and maintaining coverage through the MSP. And HR 1 includes a 10-year moratorium on the implementation of those two rules. And so they basically delayed the implementation of those two rules, which were really expected to lighten the burden and increase enrollment in the MSP program. The CBO has estimated that it's going to increase the number of people who are uninsured by about $400,000 and decrease federal spending by about $122 billion. I want to point out, I think that it's a relatively small number of people, but they are very sick people. And we recently did some research that was published in the spring showing that when people lose their low income subsidy, so the subsidy that pays for Medicare Part D copays, it actually substantially increases mortality rates. And so we estimated that based on this provision that's in HR 1, it's going to cause an additional 18,200 deaths annually just due to loss of the prescription drug subsidies. Another provision another special population I want to talk about is nursing homes and nursing home residents. So nursing home care is currently required, a required benefit under Medicaid. And Medicaid is the primary payer of long-term care in this country. So they pay for 63% of all nursing home residents and 44% of total spending in a nursing home. The lower percentage of spending because the rates that Medicaid pay are lower than the rates that private payer Medicare pays for post-acute care. So with the reduced funding from the federal government for nursing homes, states have a number of options to try and maintain coverage or to try and account for the reduced availability of funding. Because it's a required benefit, they can't drop nursing home care from the Medicaid benefit that they provide, but they can change eligibility for nursing home care. So eligibility for Medicaid is determined based on income and assets. Many states are already at the minimum income and asset requirements, but other states will be able to reduce those requirements and make it harder to enroll in Medicaid for coverage of long-term care. States can also reduce the daily rate they pay nursing homes through Medicaid for the care of people residing in a nursing home. This is also going to put pressure on nursing homes to reduce the costs that they have if they want to stay open. And nursing homes are likely to consider a number of different ways in which they can reduce costs. The general sense is that nursing homes operate at a very low or negative margin, particularly for Medicaid patients. So there's not a lot of juice to be squeezed out of this. But in other similar circumstances, we've seen nursing homes react to decrease availability of funding by doing things like reducing staffing to take care of residents who are residing in the nursing home, reducing services that are provided to residents that might include food, extra, activities, custodial services, food, things like that. I said food already, or reduce infrastructure spending. And so maintenance of the building and things like that can be a place in which we might expect to see reduced spending. And the ultimate result might be that nursing homes could close, and so there'll be decreased availability of long-term services for people requiring institutional care. Another key provision of the HR1 that's going to affect nursing homes is the delay in the implementation of a nursing home staffing mandate. So we know, based on pretty high quality research, that nursing home staffing levels improve quality of care in nursing homes. So the more staff you have taking care of residents in a nursing home, the better care they receive, the fewer adverse events they have, the lower mortality they have. HR1 includes a 10-year moratorium on enforcement of another Biden-era rule, which was to implement a minimum staffing floor, a mandate for a minimum staffing floor across all nursing homes in the country. And if it was implemented, it would have increased staffing levels in 83% of nursing homes in the country who are currently operating at staffing levels below what this minimum proposed floor was. And so it would have had a really significant and important effect on nursing home staffing levels. But that's been delayed by 10 years. And based on an established relationship between nursing home staffing and mortality, some research that we've done through the Leonard Davis Institute has estimated that it will lead to an additional 13,000 deaths annually. So another important part of HR1. And then the third group I want to talk about is people who receive their care through home and community-based services. And so most people prefer to receive long-term care at home rather than in an institutional setting. Medicaid has made that possible for many people who qualify for Medicaid. And they do that through the funding of the home and community-based services. It accounts currently for about 59% of Medicaid spending on long-term care, and it has grown really rapidly over the past couple of decades as Medicaid has tried to turn more of their long-term care spending away from institutional setting and move it to the home-based setting. And these home-based services provide they try and provide wraparound services for people living at home who have institutional level need for care. And so that includes providing not only home-based services, but adult daycare, providing caregiver support, equipment, transportation, home modifications. So all the types of things that you might think that people need to be able to maintain their independence in a community living setting. One of the concerns is that home and community-based services are an optional benefit under Medicaid. Unlike nursing homes, which are a required benefit, HCBS is an optional benefit. It is funded primarily through waivers and a few other mechanisms to fund this optional benefit. Currently, nearly every state offers home and community-based services in some form. But what we expect to happen is a reduction in the provision of these benefits because it is optional. And actually, we've seen this previously, and that was when the Great Recession in 2008 and the passage of the ARRA with enhanced Medicaid funding, when that expired in 2011, so Medicaid availability of Medicaid funding was reduced. All states reduce their spending on home care through home and community-based services. So again, we would expect under HR1, the availability of home care is going to decline. And then I'm just going to end on the implications of that for a group of people who really hold together the long-term care system, and that is unpaid caregivers. And so unpaid caregivers currently provide a significant amount of long-term care, and it's estimated that the average 65-year-old will receive about $92,000 in unpaid care over their lifetime. And so it's a lot of care that's provided for free by family members and friends of people who need help, both at home and in nursing homes. Medicaid currently provides some support through home and community-based services. That support may decline. Nursing home staffing may decline, requiring more support in nursing homes for residents there as well. And so with these reductions in spending and in Medicaid enrollment, we do expect to see an increased burden on unpaid caregiver, which will have significant impacts going forward. That's the end of my talk.
Okay, thank you so much for that. That was really comprehensive. Amber, how is this going to hit on these very marginalized populations? It's a big concern. There's a lot of frailer, older people out there.
Yeah, Liz, I'm gonna share my screen and walk through here. Are we seeing that okay?
Yep.
Great. So thanks for having me here today. As Liz noted, my name is Amber Christ. I'm the Managing Director of Health Advocacy at Justice and Aging. For those of you who may not know Justice and Aging, we're a national legal organization, and we're working to end senior poverty by making sure that older adults with limited resources can get the healthcare and financial security they need. So I'm going to cover a bit of what Rachel covered, but we agreed that with the complexity of what we're talking about here, there is absolutely no harm in repeating. So I did want to start off today by kind of just centering older adults in the big picture of the Budget Reconciliation Act of 2025, or what I'm going to call HR 1. So on this slide is the visual representation, which was developed by the Congressional Budget Office, that shows how average household resources will be impacted by the law. And so on the left side, you can see that those with the lowest incomes will see their household resources decrease, and decrease by the most, by 3.1%, which equates to about $1,200 a year, while those with the highest incomes will see their household resources increase by 2.7%, which equates to about $13,600 a year. And the losses for those with the lowest income are a result of in-kind transfers, basically from Medicaid and SNAP food assistance. And the increase in household resources are for those with the highest resources or highest incomes are a result of having to pay less in taxes. So if we put that a little bit more simply, basically HR 1 paid for tax cuts for the wealthiest people in this country by cutting public programs for the people with the lowest incomes. And that context is important for this conversation because most older adults live on very limited resources and will be negatively harmed by the law's passage. The median income for older adults is $29,740. 70% earn below $50,000. And if we look at overall household income, the average household income for those 65 and over is almost $57,000, and that's the lowest of any age group. Nationally, 15% of older adults live in poverty, with wide variation across states, and higher rates of poverty among older adults of color and women. And this year, census data showed that older adults are the only group to experience an increase in poverty, and that rate has been increasing every year since 2020. So sometimes there's a misconception that older adults are doing okay financially, and that really isn't the case. Most older adults are living on very limited resources and rely on the public programs to help them maintain their health and their economic well-being. Yet, HR 1 cuts those very programs. It is making, as Rachel noted, the largest cut to Medicaid in history, which includes approximately $990 billion in cuts, and 10 million people are expected to lose coverage. It cuts SNAP or food assistance by $187 billion, with 4 million people anticipated to lose coverage. And it also makes really big cuts for people who have lawful presence as immigrants enrolled in both in Medicare and Medicaid, also ACA marketplace subsidy help, and SNAP. So it's going to leave many older immigrants with no options for healthcare or food assistance. So if I turn to some of the particular impacts on healthcare, I think it's important that we again review just how important Medicaid is for older adults. Of course, Medicare is the primary healthcare program for the nearly 7 million older adults age 65 and over, and adults with disability under age 65. But Medicare has really big gaps in coverage and can be really expensive. And Medicaid fills in those gaps in coverage and makes Medicare more affordable for Medicare beneficiaries with limited resources. Rachel noted that there's 12.5 million people who are dually enrolled in both Medicare and Medicaid. And if we break that kind of out, there's 7 million older adults who are relying on Medicaid and 10 million people with disabilities who might just have Medicaid only and not also be enrolled in Medicare. And of course, there are millions more aging adults, people with disabilities, people with chronic conditions, and caregivers who are insured through Medicaid expansion. So Medicaid expansion is that expansion of Medicaid under the Affordable Care Act to adults with low incomes. So there's more than 5 million aging adults aged 50 to 64 enrolled through Medicaid expansion, and over 4 million family caregivers enrolled through Medicaid expansion for their own health care. And as Rachel noted, Medicaid's broader than typical medical services. It includes services that are particularly important to older adults and people with disabilities. So this includes notably long-term care. Medicaid is the primary payer of long-term care in this country. That's long-term care provided through the community, through those home and community-based services that Rachel talked about, or HCBS, and through nursing facility care. It includes coverage of transportation to medical appointments. And notably, it includes that financial assistance to pay with Medicare out-of-pocket costs, including those Medicare premiums, co-pays, and co-insurance to the Medicare savings programs. So cuts and changes to the Medicaid program have enormous implications for the health and well-being of older adults. And despite claims to the contrary, we heard a lot during the debate of HR 1 that older adults wouldn't be impacted, and I think it's very clear that they will be. So as Rachel noted, the HR 1 makes direct cuts to federal funding to states. So states will receive less in federal funding. And it also does this with SNAP. So states are going to have, the cost will be shifted to states, and states are going to have to figure out how to make up for that loss in federal funding. And for older adults, what we're worried about, as Rachel noted, is that states are going to turn to cutting benefits that are optional under federal Medicaid law. But those optional benefits are what's so critical for the health and well-being of older adults and disabled people. So optional benefits include those HCBS. So again, these are those services that help people remain in the community rather than having to go into an institutional facility or entirely rely on family to provide that care. And HCBS account for 51% of optional spending in the Medicaid program and 32% of Medicaid spending overall. So it is a big budget line. And as Rachel noted, historically, when states are facing budget shortfalls, it's these optional benefits that states turn to cutting. And during the Great Recession, every single state cut HCBS. So we anticipate that that is definitely a target, would be a target this time, as well as dental vision and hearing. Of course, states could also turn to cutting enrollment. They could cut provider rates, which would worsen the direct care workforce shortages we're already facing. And it could lead to those nursing facility closures that Rachel noted, or closures of hospitals, particularly in rural areas. Of course, these cuts aren't inevitable. States could take steps to increase state revenues, like raising taxes, but that's a really big lift. And with budget holes of the magnitude states will be facing, they're just in a really tough spot with very few options. So it's hard to imagine a world in which HCBS won't be a target or other optional benefits. And in fact, some states have already taken steps to start cutting their Medicaid programs in anticipation of what they'll be facing because of HR 1. And they've cut, for example, provider rates across the board. So we're already seeing states take action. States also made changes directly to Medicaid eligibility that directly impact older adults. As Rachel noted, it paused the Medicaid eligibility and enrollment rules, or what we like to call the streamlining rules. These were the rules that were finalized in 23 and 2024 in recognition that it's really complex enrolling in Medicaid for older adults and people with disabilities. And as a result of that complexity, many eligible people are left out. So now those rules are paused. HR 1 also reduced the coverage Medicaid provides retroactively for older adults from 3 months to 2 months. So that's going to increase the risk for older adults having medical debt and could also lead to delays in care and nursing facilities. And as I noted at the outset, HR 1 really targets eligibility for lawfully present immigrants. And in Medicaid, it cuts eligibility for refugees, asylees, and other lawfully present immigrants, leaving these individuals without any healthcare coverage at all. HR 1 also made changes to the long-term care. It includes changes to the financial eligibility for long-term care. The law freezes the home equity limit at $1 million forever. It won't move for inflation like it previously did. This will make it harder for people who need long-term care to keep their home, especially over time as housing prices dramatically increase. And it also puts on pause that nursing facility staffing mandate that Rachel noted that would have put in place minimum staffing standards in nursing facilities and estimated to save those 13,000 lives a year. And then HR 1 particularly targeted Medicaid expansion. Again, while Medicaid expansion does not include older adults 65 and over or people enrolled in Medicare, millions of older people aged 50 to 64, people with disabilities, people with chronic conditions, and caregivers are enrolled in Medicaid expansion. And the law puts in additional barriers to coverage in Medicaid expansion. It will require states to redetermine eligibility for expansion every 6 months instead of yearly. This administrative burden puts pressure on the entire Medicaid program, including processing Medicaid applications for older adults and people with disabilities. And as Rachel noted, these are put in place to save money by getting more people off of the program who otherwise probably would be eligible, but the administrative burden will have people kicked off. For the expansion population, it also cuts retroactive coverage. Instead of going down to 2 months, it goes down to 1 month. Again, that will increase risk for medical debt. And when I'm thinking about the impact on older adults and disabled people, there are a lot of individuals who are disabled and have applied for Social Security disability, but are in the 2-year waiting period for Medicare, who this could particularly impact. And then it requires states to impose some level of cost sharing on the Medicaid expansion population. Again, while people over 65 won't be subject to this directly, it does increase the likelihood that older adults will be billed for services, since now providers will be billing some portion of Medicaid enrollees for cost sharing. The Medicaid program has different eligibility pathways and different populations it's serving, but it is a program administered by the state. And so changes in one part of the program impact the entire program. We can't really sever the program from each other. So older adults and people with disabilities are going to be impacted by these changes, even if they're not directly impacted by the policy change. And arguably the most fundamental change it made in HR 1 was putting in place community engagement requirements or work requirements specifically for the expansion population. Again, in theory, this does not impact older adults over 65 or people on Medicare, but it will impact the millions of aging adults ages 50 to 64 and people with disabilities and chronic conditions and their caregivers, who will now have to prove they are working or meet an exemption for this requirement to maintain their healthcare coverage. And the Congressional Budget Office estimates that about 5 million people across the country will lose coverage because of this requirement. Again, not because they aren't working or don't meet one of those exemptions, but because of the red tape of having to prove it. This will also mean that states, and they're already doing this, are reallocating enormous amounts of resources to implementing and administering these requirements. And that burden puts pressure on the other parts of the Medicaid program and then likely impact older adults and people with disabilities in applying, having their redeterminations done, and facing any issues in the Medicaid program. So in addition to Medicaid, there are also some changes to Medicare. HR 1 cuts eligibility for many lawful immigrants who are currently enrolled in Medicare or who would otherwise be eligible in the future for Medicare, despite having paid into Medicare and being eligible. So because they are not going to be eligible for Medicare, they can't enroll in Medicaid, and they can't receive financial assistance through the marketplace, they'll have no form of healthcare coverage. So it's leaving these people entirely without coverage. HR 1 also triggers cuts to Medicare unless Congress acts under a wonky rule, as if all of this wasn't wonky enough, called the pay-go rule. Because HR 1 put in place deficits, $3.1 trillion in deficits to be exact, it triggered this rule that leads to sequestration. And so Medicare would be cut by $500 billion, a little over that. We do anticipate that Congress will act to address this. They've always done so in the past, but it remains an unknown. And obviously that would significantly undermine the Medicare program as well. I'll end with SNAP. The law makes unprecedented cuts to SNAP as well. It cuts federal funding to states, and then again, states are going to have to come up with how they're going to make up for this loss in funding. So we anticipate cuts to SNAP for all populations relying on SNAP, including older adults, which will decrease the overall assistance going into households and put pressure on other basic needs. And it also expands work requirements in the SNAP program. Work requirements were already in place in SNAP prior to HR 1, but the law expands the requirements to older people 55 to 64, veterans, and unhoused people. So they were previously excluded from the requirements, but now will be subject to those requirements. And also, like we saw in healthcare, HR 1 restricts SNAP to lawfully present immigrants who previously had eligibility, so they're not going to receive that food assistance either. I have included some resources at the end of my slides, some of our resources from Justice and Aging describing the impact of HR 1 specifically on older adults, as well as some additional resources on the law's impact. And I'll turn it back to Liz. That's the end of my talk.
Okay, thank you so much, Amber. That was great. So let's start off with a couple questions. Let me remind our viewers to please put your questions in the Q&A. We've got time to take questions from the audience, but I guess the most pressing thing right now, we were chatting a little bit before we went live, is the government shutdown and what impact that might have on any of the proposed Medicare cuts. The Democrats are saying put the subsidies back in. They want some of the Medicaid cuts restored. Is that any of this really going to happen? I mean, I know I'm asking you to predict the complete unknown at this point, but any thoughts on the shutdown and how that might affect anything?
You want to go, Rachel? I guess a couple thoughts. So the shutdown, I guess, like thinking about Democrats are saying that the reason that they wanted a budget agreement that looked different was because they wanted to include the renewal of the enhanced premium tax credits. And I didn't talk about those because they weren't part of HR 1. They weren't addressed at all in HR 1, but they're set to expire at the end of this year. And with that expiration, people's health care on the marketplace will significantly increase, in some instances up to 500%. And that particularly impacts older people enrolled in the marketplace because they have higher premiums and higher risk scores. With that expiration, we could see enormous increases in the cost of healthcare. So that was the driving force, as well as, Liz, you said, repealing some of the cuts to Medicaid in HR 1. Now, whether there's an agreement on that, I cannot say. It feels really intractable at this point, but that's sort of the debate right now. Additionally, the government shutdown is having other impacts on healthcare, and I think HR 1 in that the government isn't really operating right now. So to the extent that states are needing guidance on how to implement this, or things are happening in communication with the Centers for Medicare and Medicaid Services, a lot of that has likely drawn to a close. I tried to look at a census document today, and the census document wasn't available, saying that, which I just looked at yesterday, because of the government shutdown. So just communication is stalled, which just on a timeline that is as abbreviated as HR 1 is, has its own impacts. And of course, there's actual direct impacts to healthcare, including like surveys and nursing facilities, the availability of telehealth, that all did not get extended within or paid for now that we have a government shutdown. I don't know, Rachel, if that prompted something for you too.
I mean, yeah, that was a great summary. I guess I'll just say about the enhanced premium tax credits, which seem to be at the core of the disagreement about the shutdown. You know, those were introduced after the pandemic to try and increase the number of people who have insurance, and they were actually really very effective at decreasing uninsurance rates in this country. And so loss of those credits would those subsidies would likely really increase the number of people who are uninsured. And I think that one of the important things when I think about that group of people who are going to be at risk for losing insurance is there's a lot of near elderly in that group. So not older adults traditionally who are on Medicare because they're unaffected by the ACA, but there are many people, almost half of people who get subsidized care through the ACA, through these enhanced premium tax credits, are near retirement and have, saved and scrimped so that they can retire early. And the reason that they can retire early and sort of sever their employer-sponsored insurance is because they can get insurance through the marketplace, the ACA marketplaces. And so I think it would be naive to think that this isn't going to affect people that we know and that who are our colleagues and who are our neighbors and our friends, and many people who it's going to be a financial burden on many of these near elderly that we've been talking about who are then going to have to wait until they age into Medicare. And so I think whether it's going to be successful, I wish I knew, but I will say that if it's not, it's going to have a big impact on the health of this country.
One of the other things that concerns me is that Medicare premiums, Part B premiums, are going up next year. Part D premiums are going up, at least according to the people I've spoken with who are on, Part D and starting to get those notices. And with open enrollment starting next week, um, how will all these factors that premiums will be harder to pay for, they may not be getting the kind of assistance through Medicaid to help with some of those premiums or to help pay for their drugs. And they're now, perhaps if older people are on food assistance, that's getting cut as well. So a lot of people are going to be put in this situation of not being able to afford their premiums, not being able to afford medications, and not being able to afford food. Um, Rachel, you're a doctor. I mean, what is this like almost the apocalypse scenario?
I mean, there's many things at the moment that feel like the apocalypse, I will say. But I think it's very hard to predict. But the thing that was running through my mind when you were talking, Liz, is that I think an important distinction that we haven't made yet is the people that we're talking about that are most at risk are among the duals. So among the low-income Medicare beneficiaries who may have to pay the high premiums and copays for Medicare Part B and D, that's less than half of Medicare beneficiaries. And so, we currently have more than half of Medicare beneficiaries enrolled in Medicare Advantage, many of them at zero premium, in zero premium plans. And actually, they get many of these sort of supplemental benefits through their MA plans. And so I think one of the things that we haven't quite figured out or don't really talk about is this may really disrupt the balance we currently have between traditional Medicare that we're talking about and Medicare Advantage, and really further accelerate the growth in Medicare Advantage. And that's a topic for another day, and whether that's a good or a bad thing is a complete unknown. But I think it is going to sort of make people seek out other ways to try and make ends meet, because as you've pointed out, it's going to be a big financial burden for people if they don't have help with these premiums and other copays.
Amber, anything you want to add to that?
Nope, couldn't agree more.
So we have a couple questions coming in. What happens to home and community-based services for those on Medicare rather than Medicaid? And if you can draw the distinction between what Medicare pays for versus what Medicaid pays for, because when we think home care, it all kind of blends together.
So I'll start and then hand it over to Amber. So Medicare doesn't pay for home and community-based care traditionally. And so, there's as I was just saying, there's like two flavors of Medicare. There's traditional Medicare and then Medicare Advantage. Focusing for a minute just on traditional Medicare, which is what we've been talking about, they don't pay for home and community-based care. And so what fills in the needs for people who are at home, for people who are in traditional Medicare, is caregivers, unpaid caregivers, or family members and friends who help people at home. Home and community-based services are paid by Medicaid for people who qualify, but they are paid, and that's super important. I don't want to minimize the importance of that. It is an optional benefit for Medicaid, and it is paid at a relatively low rate, so it leaves gaps in coverage for people. Among people who are in Medicare Advantage, they do get some of those home and community-based services through what we call supplemental benefits. But we just don't know that much about how often supplemental benefits are used, because the way that the information is set up is just very opaque, and it's very hard to understand who's using it and how much they're benefiting from it. So it's really the loss of Medicaid for people where we start to worry about loss of home and community-based services.
Yeah, the only thing I would add is that we've had this infrastructure that's been inadequate, right? That Medicare doesn't really pay for the day-to-day home and community-based services. Medicaid is picking up, but it's a patchy system, as Rachel noted. And then those patches and those gaps are being filled in by unpaid caregivers. And what HR1 does is it further exacerbates that, right? It just it makes those gaps bigger, and exponentially bigger, possibly. So yeah, it doesn't really directly impact the Medicare, but it does impact the overall long-term care infrastructure.
And I might just add one thing. Part of the reason I think this is confusing is that Medicare does pay for home health care. So like we're gonna like draw a distinction between shades of gray at the moment, but home health care is a Medicare benefit that covers what we call the skilled need. So if somebody has basically a medical need or rehabilitation or something like that, they can get visits from a home care agency, and there's limits on those visits and rules around who qualifies for home care visits. And, you know, when you look at the number of people using home care over time, it's actually increased. And one of the things that we wonder about is whether or not people on Medicare are using it sort of as a substitute for home and community-based services when they can't access home and community-based services. But it's probably even less adequate as coverage for people who need help with activities of daily living than home and community-based services are.
So, got another question here about why did Congress end the ACA subsidies? Was it truly to end, tied to the end of the pandemic, or was it just keeping the cost down for the government? If you can go back and kind of remember that legislation, did it have a sunset on it? It did.
Do you want to go first?
Go ahead, Rachel. Yeah.
Well, they haven't ended the subsidies yet. I mean, so the subsidies were passed, I think, the first time in 2021 and then renewed in 2023, and they're set to expire at the end of this year in 2025. And so part of the fight in Congress right now is over whether or not we're going to renew them again or make them permanent.
Right.
Yeah, it's a big issue because kicking millions of people off of healthcare because they can't afford the premiums is kind of a big deal. Do you see that just kind of going from a left hand, right hand thing? Because if people can't afford healthcare, we go back to the way it was where you start relying on the emergency room as your primary care provider. That's bound to increase overall health system costs rather than doing preventive care and screenings and that kind of thing. So is this really saving money?
I would say no.
Magic math, right?
No, I mean it's shifting costs onto hospitals and uncompensated care. It's shifting costs onto people through medical debt, and it's shifting costs onto people's lives through poorer health and lower life expectancy. So no, it's not really saving anything other than federal dollars in the short term.
So what about the future of the state health insurance plans due to HR1? I think what Richard's asking about is the navigators. You know, we have, I mean, I live in New York. It's great. I called them when I was ready to think about Medicare supplemental plans. Because even for somebody that kind of knows what it's all about, it's still very confusing. Do you see like support services like that also going away, or is it state by state?
Uh, well, I'll start off by just making a distinction between HR1 and the yearly budget appropriations. So I find that confusing because we're calling it the Budget Reconciliation Act. So it sounds like, oh, budget, right? And it does impact the budget, but it's not our annual budget process with appropriations, which is what the government shutdown's about right now, is that annual budget and appropriations. So HR1 really doesn't address SHIPs, the Medicare counselors, the state health insurance programs. The annual budget, however, does, and every year the money needs to be appropriated through discretionary funding to fund SHIPs. And at one point, the president's budget eliminated that funding. It was added back in. So it's always at risk. And I think particularly at risk in this current environment where we're seeing cuts to programs across the board. And we already know that SHIPs are woefully underfunded, particularly considering the complexity of the Medicare program. And if you're dually eligible, the intersections between Medicare and Medicaid and having to know Medicare Advantage and Medicaps, it is incredibly complex for people to make these decisions and receive the help they need. So the SHIPs are already underfunded. So yes, we think that it's certainly a risk. Yeah, I don't know, Rachel, if you wanted to add anything.
Okay. One of the things I'm really curious about, we've seen coverage on the shutdown. I haven't seen a lot specific to older adults. What would each of you like to see in terms of coverage? What's not being reported that we should be focusing on? Because this is a big topic with a lot of wonky kind of details. How can local reporters, kind of put their heads around this?
Yeah, I would say the shutdown right now, it's taken all the air out of the room, right? And I would note that there's a lot of misinformation out there right now about why the shutdown is happening and what is being called for, particularly around immigration. And I think that there's a lot that the media could do and journalists could do to make sure that people understand that nuance and the facts. With regard to HR1, I think the policy details here are complex, but the impact on the health and well-being of older adults is straightforward. These are the largest cuts to Medicaid at a time when our aging population is growing. We're seeing more seniors aging into poverty. As a country, we were already underfunding our long-term care system, and many seniors and their families were struggling to get the help they need today. So these cuts really undo decades of progress and risk driving more older adults and their families into crisis. And I think that there's a reason why the harmful cuts aren't set to take effect until like after the midterms. And that's because lawmakers knew what the devastating impact would be, and they didn't want to risk losing their jobs. But like I said before, the truth is that some states are already starting to respond by cutting their Medicaid budgets. So people are going to start feeling this impact sooner. So I think it's just really important to tell those stories. And again, that impact is really clear.
Yeah, I think telling stories about the effect this is going to have on individual people is the way to make this understandable to the general public. I think that part of the task is making this people understand that it's people just like you and I that are going to be affected by this. It's not some other population that we don't see and that we don't interact with and that we don't have responsibility for. This is like a very large segment of the population that we work with and see every day. And I guess the other piece that puzzles me, with healthcare, I think is a winning issue, which is, as Amber said, why the implementation has been delayed, but it's also an economic stimulus for this country. And so which is why we see during recessions, money being poured into Medicaid. And so I think it's about the health of this country, which is perhaps the most important piece, and people's lives and well-being are at stake, but it's also about the economic well-being of this country and of individuals.
That kind of brings me into my next question. I mean, we've talked a little bit about the impact on family caregivers who will have to step up even more if some of these home and community-based services are cut. That may force some people to have to cut back their work hours or even give up their jobs altogether. So now they're without employer-sponsored health care, maybe don't have, can't qualify for Medicaid. And they're taking, there's a couple of hits to the economy here. How do you see this all, working out we're already, battling some inflation. We're already talking about maybe a recession. What is this going to look like when we get through the next couple of years?
Yeah, I mean, I think this is one of the worrisome things that we don't spend enough time talking about is the impact this is going to have on caregivers, because it's very hard to quantify, and they're not, it's sometimes a little bit, it's always been invisible. They're the invisible workforce that keeps the long-term care system in place. But I think that, you've highlighted, Liz, the economic burden it's going to be on caregivers as they have to step back from their employment outside of the home. I also worry about the many other impacts it has on caregivers. It not only adversely affects their economic well-being, but also their mental health or physical health. It causes people to forego retirement savings. Your Social Security payments are tied to your employment. If you work at a company that provides retirement or pension, you forego that. And so I think there's just like many ways that we don't do a great job quantifying in which it's going to really have an adverse impact on caregivers. And I think that I would also say that caregivers, 90% of caregivers are women. And part of the reason I think that it's very hard to make a lot of progress on this is because this is a group of people that generally don't have a lot of political capital. And so I think it's very easy to just push this off onto the caregivers and not spend a lot of time worrying about it.
I couldn't agree more, Rachel. And it's sort of the compounding impact and the driving intergenerational poverty. Like that reduction in retirement savings means that they're going to be more likely to age into poverty and rely on the inadequate system that they're currently a part of. It's just like perpetuating this rather than putting in place policies that actually help people rise out of poverty, and it is disproportionately impacting women and women of color in particularly.
Yeah. So we had a question about, Rachel, you said healthcare is a winning issue, but a lot of people have said that, healthcare isn't necessarily top of mind for them in the last election. How do you define winning issue?
Yeah, I mean, it's interesting, the ACA is a long and storied history, the Affordable Care Act, and its popularity when it was first passed was pretty low, and people weren't sure that it was a good thing for this country. But over the decade plus in which we have been implementing the ACA and trying to build a more robust healthcare system, the popularity of that program has really increased because I think people have seen the benefits of being able to get affordable insurance through the marketplace and the benefits of not having your insurance tied to your job and things like that. And so I think that trying to take away, when I say healthcare is a winning issue, trying to take away something that we've already given people is rarely the winning issue. And so I think that's when I say healthcare is a winning issue, I think that it may not be top of mind for people until we take away their health insurance. And then we should ask that question again.
Makes sense.
Yeah, and I'm struck sometimes by this, or all the time, that HR1 was in large part a repeal of the ACA, but without any form of replacement. We are leaving people completely in a lurch without any coverage. And again, I think that's why that impact is set to take place after the midterms, but it also it doesn't make sense in people's lives. And that I think will be like people will start to feel that and talk about that. And those are the stories that we should be uplifting because it is, there's just nothing there for people at all.
So I think we have time for one more question, and I want to kind of combine this. We've talked about the direct care workforce and how it relates to both home and community-based services and nursing homes. Services, particularly in the community, have to be provided by certified agencies who are now at risk of getting cuts to their Medicaid reimbursed payments, which makes it harder to attract and retain skilled, dedicated workers. And these workers are also moving to jobs, at Target or at, the mall, where they can make pretty much the same money or a little bit better and perhaps get benefits. I mean, you work part-time at Starbucks and you can get benefits. What is this going to do to the existing ability to care for our seniors, regardless of the location?
So I'll start by saying I think that we are already facing a crisis in the direct care workforce because we have a shortage of workers, and it's particularly acute for home care workers, but also direct care workers in nursing homes. Ever since the pandemic, the problem has been more apparent. It's in part due to the fact that these jobs aren't desirable because the pay is low, Liz, as you've said. I mean, the median pay for home care workers is less than $17 an hour, so barely above what we consider a living wage. Many of people who are direct care workers live in poverty, and I think I looked it up before we got on this call. 59% of direct care workers receive public assistance. 37% currently receive Medicaid. And that's before the Medicaid cuts, but this is a workforce that really already relies on the public programs that we have in place. Not great jobs. That's evidence of their sort of low pay, low benefits. And so I think the provisions that are in HR1 are going to make this worse. We're going to cut pay even more than we have. People are going to need financial assistance through public assistance programs, which are also being cut at the same time. And so there's going to be fewer people around to provide the care that we need to the growing aging population that we have in this country. And I could go on, but and maybe I just want to make two other quick points about the
Sure.
workforce, which aren't directly related to HR1, but are related to other things that are simultaneously happening. One is that a large portion of the direct care workforce are not US born. Many of them are naturalized citizens, but a large number are immigrants. And as we move forward with immigration enforcement and deportations, it's having a direct impact on the direct care workforce, and it's decreasing. I have done research with a colleague showing that it decreases the number of available home care workers, other research showing the same thing in nursing homes, and that has real impact on the people who need care. There's also a proposal out from the Trump administration related to the Fair Labor Standards Act to remove home care workers from protections under the Fair Labor Standards Act. And what that means is that they would no longer have to be paid minimum wage or have overtime pay as other jobs do. And this is being done under the guise of addressing the shortage in home care workers. In my view, and the evidence that we have to date is it's only going to make the shortage worse.
Amber, anything to add?
No, I will just say, we've talked about the caregiver workforce being invisible, and that just is a rendering of them invisible even more in policy, right? And value is what these proposals are doing. And that impact is on those individual caregivers and their lives and their livelihood, but also on the people they're providing care to, who will not receive that care or will receive substandard care as a result. So it's just compounding impacts here.
Well, I think that in itself gives us multiple story ideas also to report on because the senior population is only growing, and certainly, as you say, there's been an issue with the direct care workforce. I think I saw a projection we'll be short like 1 million direct care workers in the next decade or something like that. So something else for the audience to keep in mind. I want to thank both our guests for giving of their time and their expertise today. And thanks to all of you who tuned in. If you joined us late, you'll find the recording of this webcast at healthjournalism.org in just a few hours. AHCJ will continue to bring webinars on a variety of health topics as a perk of your membership. Thank you, and good luck with your stories. And thanks again to Amber and Rachel.
Thank you.